Welcome back, everyone. How is the sound? Jessica, go ahead and say hello to everybody.
Hi, everyone. Happy Sunday.
Can you hear us both? As soon as we've got our thumbs up on our sound. Yep, we've got our thumbs up. That's great. So, once again, I am Jenny Williamson, the Executive Director of the C3 Foundation. On behalf of myself and our founder and CEO, Claudia Christian, we are so glad you are watching our second annual virtual TSM conference, Stronger Than Your Drink. Please feel free to use the chat function if you're watching live on Twitch to ask questions all throughout the panel. I'll be collecting them and asking our presenter your questions during the Q&A following the presentation. The conference is available to view and to participate in for free thanks to our two co-headline sponsors, RIA Health and Work It Health. If you'd like to support the work of the C3 Foundation, there's a donation link in our profile, and we also have a timer that's dropping donation link into the chat during the broadcast. And if you're on Twitter today, please feel free to live tweet our conference with the hashtags Stronger Than Your Drink and Options Save Lives. It's a great way to amplify the impact of our conference and maybe even bring in some new viewers. Next up, we have Jessica Shea presenting about trauma-informed substance use recovery. The panel is sponsored by Web Doctors, which I just noticed. There we go. Now we have our panel sponsor text up there for all to see. Jessica Shea has worked in the mental health field for 14 years and approaches counseling and consulting from a values-based perspective, guiding her clients to investigate and solidify their core values and work toward rebuilding their lives or their company around these beliefs so they can experience flow. Jessica is a trauma-informed therapist and believes that where you see a person suffering, there is a chance for that person to heal and grow. She utilizes ancient and progressive interventions to get fast results with clients to resolve post-traumatic symptoms and problematic habits. Jessica is the founder and CEO of Forward Counseling and has 20 years of experience as a business owner and entrepreneur. She is also the founder and executive director of You Can Sit With Us, which offers business-to-business coaching and consulting. She's owned various types of businesses, served on numerous nonprofit boards, and is also a trauma survivor and healer. She has helped people overcome severe childhood trauma, overcome addiction, overcome depression, and harness the energy of anxiety or anger. She's helped some of those same people go on to launch profitable and fulfilling startups. So whenever you're ready, Jessica, I'm going to go ahead and hide myself from the screen and let you start whenever you're ready.
Thank you so much. I appreciate the warm welcome and great introduction. Appreciate that. So to start, I want to read you guys part of a story. I find children's books to be sometimes the best way to intervene with people. And this is one of my favorites. It's called Bottle by Oliver Jeffers. We're not going to read the whole thing. We're going to read a part of it. And I think this gives a really good feel of PTSD and trauma. So I'm going to read it to you. So if you would get comfortable, take a deep breath and ground yourself in this moment and then in your seat. Notice what you see, smell, and taste around you. Notice if there's anything happening in your body. See if you can relax the parts that are tense. Just, roll your shoulders back, make sure your feet are on the ground, do a few deep breaths, and thank you for being here with me today. Once there was a little girl, much like many other little girls. And I'm going to read it to you like you did in second grade, too. Whose head was filled with the curiosities of the world. With thoughts of the stars, with wonders of the sea. She took delight in finding new things, making some art, until the day she found an empty chair. Feeling unsure, the girl thought the best thing was to put her heart in a safe place, just for the time being. So she put it a bottle and hung it around her neck. And this seemed to fix things. Although in truth, nothing was the same. She forgot about the stars and stopped taking notice of the sea. She was no longer filled with the curiosities of the world and didn't take much notice of anything, other than how heavy and awkward the bottle had become. But at least her heart was safe. So what is trauma? What did this little girl just experience? In the book, it was loss, but I'm going to review just a few different types of trauma that many of us have experienced. So trauma is an emotional response after a terrible event happens. It can be any kind of terrible event. It can be what we call a big T trauma or a little T trauma. It could be like a rape or an assault, but it also could be little T traumas like neglect, poverty, living in a stressful neighborhood, physical and emotional abuse, childhood neglect, dealing with racism and oppression, dealing with microaggressions in your school or workplace. Dealing with discrimination has even been shown to cause PTSD symptoms. So in our country, around 1 out of 5 people have experienced sexual abuse, and around 1 out of 4 have experienced child abuse. And I'm going to get into a little bit more of how common these things are. So how common is trauma? We have a great study that Kaiser Permanente did. It's called the ACE study, and it was done from 1995 to 1997. And they interviewed 17,000 people. They interviewed them and followed them. So what they did was ask them different questions about their childhood. And this is known as the ACEs score. ACEs stands for Adverse Childhood Experiences, and this study has been very impactful in intervention since then. So what we learned from the ACEs research is that around 40% of Americans experience 2 or more traumatic childhood events, and around 12% have experienced 4 or more. And we'll see why this is significant in just a minute. Trauma-informed care understands and considers the pervasive nature of trauma, which is what we just talked about. The fact that 1 out of 4 of us has experienced childhood abuse, and 1 out of 5 of us has experienced sexual abuse. Trauma-informed care understands that we can come from this background, and it promotes environments of healing and recovery rather than practices that may re-traumatize. The long-term effects of trauma on health, as found out through the ACE study, people with an ACE score of 4 or more are 2 times as likely to smoke. They're 2.5 times more likely to have a sexually transmitted disease. They're 4 times more likely to have chronic pulmonary disease. They're 7 times more likely to be an alcoholic. They're 10 times more likely to inject street drugs, and they're 12 times more likely to commit suicide. So childhood trauma has significant health implications. And it's not just addiction, it's even diabetes, heart disease, even conditions that we haven't really related to trauma before this study. So when the ACEs study also concluded that there were behavioral outcomes related to childhood trauma, depressive episodes, sleep disturbances and insomnia, higher fetal mortality, pregnancy issues, and negative physical health issues. So we do also know that ACEs lead to increased chance of addiction. This conference, we're particularly talking about alcohol, but in the ACEs scale, it showed increased addiction pretty much across the board. Street drugs, tobacco, food, pretty much anything that provides dopamine reward has been shown to have an increased risk the higher your ACEs score are. So common signs of PTSD are problems with anger, problems with relationship, chronic depression that does not respond to intervention, insomnia, nightmares, disassociation, anxiety, and health and medical issues. And I want to give you a little story right about now. When I was a young mother, my daughter's pediatrician noticed that something was off with me. She was in getting vaccinations. She was maybe 1 or 2. And he noticed I was just a little off. And he thought I had postpartum depression. So he referred me to counseling. And somehow or another, through my insurance referral, I ended up with a trauma-informed therapist. His name was Neil Anderson, and I'm still grateful to this man to this day. And Neil Anderson did a thorough assessment and informed me that I had PTSD. Now, at this point in my life, I had been to inpatient rehab. I had had about 7 years of treatment for substance abuse. I was diagnosed with polysubstance abuse as a teenager and began rehab. My drugs of choice were cocaine, crack, ecstasy, anything I could get my hands on, really. And the view back then was that it was a character flaw. And so I had had years of interventions, and I still had an active addiction. So Neil diagnosed me with PTSD, and this was a complete shock. I mean, after I had had psych testing, I had had every battery of tests, and this had never come up. So Neil worked with me to resolve my trauma. Neil did not focus on my addiction issues. Neil focused on my trauma issues. And gradually, naturally, over the next 7 years, my addiction issues unraveled. Neil worked with me and did EMDR, which I'm going to talk about later. And we processed traumas. It took years. But what happened over those years was my intelligence went up, my focus went up, my substance abuse went down, my parenting improved, my sleep improved, my anxiety and depression went down. Anxiety and depression were something I had struggled with since I can remember, and no clinician had ever fixed that for me. Because the issue wasn't anxiety and depression. Anxiety and depression were the symptoms, but the issue was PTSD. So if you're someone who has had chronic anxiety, chronic depression, and these things just haven't been resolved by typical methods, CBT is supposed to work for depression. If you have PTSD, CBT is not going to fix depression. So if you find yourself in this situation, I want to encourage you to get screened for PTSD. And if you are a clinician treating people with addiction issues and or depression and or anxiety, they all go together, I want to encourage you to screen for PTSD, because there's a chance that the issue is PTSD, because PTSD is like an umbrella, and under that is addiction, is anxiety, is depression, flashbacks, insomnia. All of those are considered symptoms of PTSD. So as Neil worked through this EMDR with me and trauma therapy, when we were done, I wanted to know, what did you just do? What is this? And he told me he's a trauma therapist and he's an LCSW. And I decided at that point that I wanted to do this for others. And at this point, I was in my late 20s. I was 28, I believe. And Neil encouraged me to go to graduate school. This was very intimidating because I went to undergrad and it took me 7 years. I couldn't even get into undergrad initially. I went to a 2-year state school first because my grade point average was so bad, I couldn't get into a state school. I had struggled with academic issues for all of high school and continued to struggle with them until I finished trauma therapy. So I did get into graduate school and I did much better than undergrad. That's why I say your intelligence improves through trauma therapy. The grades I made in undergrad versus the grades I made in graduate school were drastically different. And what happened was trauma therapy. So I went to graduate school and I learned everything I needed to learn, and I did great. And I opened a practice that is trauma informed so that we can help others in this respectful, humane way. So I'm going to give you guys some assessment tools. So the key really is assessment, measuring where the client is at, and then measuring your progress. These are my favorite. These are my favorite assessment tools. Here we go. These are my favorite assessment tools. There certainly are others, but these are my favorites. The Beck Depression Scale, Burns Anxiety Inventory, the TAP Substance Screen, the Clinician Administered PTSD scale called the CAPS-5, and then the ACEs scale. This battery of assessments will show you if your client has PTSD or not. I also recommend doing these scales throughout treatment because it shows if you're making progress or not. The depression and anxiety scales you can do monthly. The the TAPS is, I think, recommended every 90 days. The ACEs scale, you just do once. And the PTSD scale, you'll want to do throughout treatment. You want to do a baseline, and then you'll want to continue to measure. PTSD, I'm you after 14 years of curing PTSD is curable. And I'm going to show you in a few slides the interventions that are shown effective to cure PTSD. I want us to introduce the language of curing. I know in the mental health field, a lot of clients have been taught that you manage and that this is a lifetime diagnosis. That is true. It's not true. It's shown by evidence to be not true. It's and I really wish we would start talking about cures. So depression is curable, PTSD is curable, and addiction is curable. So those are all curable things. And as you're moving through treatment, what you're going to want to do is check the PTSD scale, and you're going to congratulate the client because at some point they will no longer meet diagnostic criteria for PTSD, which means the PTSD has been cured. The client no longer has PTSD. So what I say is I'm a former PTSD. I say I'm a former PTSD diagnosed person, or I say I had PTSD, but it has been cured. And I want to encourage you to use that language with your clients too and encourage them. This is a curable thing. This is not a life sentence. This is not going to be affecting you for the rest of your life. All right, so here is my favorite side benefit of TSM. TSM is amazing in trauma therapy. And here's why. One of the trickiest things about being a trauma therapist is your clients disassociate. Disassociation is your brain's protection. Your brain actually drugs itself with opioids under stress. So your brain disassociates under stress. Your brain produces opioids that are then absorbed by your brain. Naltrexone blocks that process, so you're not able to disassociate. This means trauma therapy is more effective. Part of what I do as a clinician with clients who are not on naltrexone is manage disassociation. If I push too hard, they check out and we can't get anywhere. But with naltrexone, the client can't disassociate. Now, here's the other thing. With naltrexone, you can't disassociate. And what that means is you're going to feel your feelings. And so part of trauma therapy is helping people understand and identify their feelings and understand that they're there to help them. They're there as a message. And it can be a little shocking. When someone has PTSD, they do disassociate. When someone has an addiction problem, and addiction is usually a dissociative process too. We're drinking to numb out, or we're using substances to numb out. This process is why people with PTSD stay in the addiction loop, is because they are not focused and grounded enough to stay present for the process, which can prevent the future use. So naltrexone blocking that process makes it a great drug to use during trauma therapy. There is a psychiatrist named Dr. Bruce Perry who has pioneered the use of naltrexone in children with PTSD. I recommend his reading. He's the one that the boy who was raised as a dog. If any of you all have read that amazing book, he actually gives naltrexone to children who have PTSD so he can do effective trauma therapy. He also gives them naltrexone so that they don't. Some children who have severe PTSD can actually pass out from the opioids that their brain is producing that numbs them. So it stops that process too. So your brain's job is there to protect you. It really is. And by working with a seasoned trauma therapist while using TSM and naltrexone, you can make amazing strides. So effective, slide this up a little. There are a number of effective interventions for PTSD. And by effective, what I mean is evidence-based. These are proven by science to work for PTSD. And I'm just going to go through them quickly. You can Google these. There's plenty of research about them. EMDR, eye movement, desensitization, and reprocessing. It's what I did for 7 years. It was amazing. Motivational interviewing, rapid resolution therapy, accelerated resolution therapy. They're very similar, so I put them together. NLP, which is neuro-linguistic programming. DBT, dialectical behavior therapy. Mindfulness-based interventions. Mindfulness-based interventions are ancient. They have been around. They are in ancient textbooks from Greece and wherever else in the world. But it is also evidence-based. Clinical hypnotherapy, CBT, expressive arts-based intervention. I love art therapy interventions for trauma work. It's amazing. Medication-assisted therapies. There are approved medications for PTSD. Typically, when I see a client on medication, they are on a mood stabilizer and an SSRI. That just seems to be the common, that's the evidence-based medications for PTSD. Psychedelic-assisted therapies. This is a new, well, they're not new. They've been around for a long time, but it's new because there is a resurgence in interest, and because of the mental health crisis, these medications have been granted breakthrough status, and there's research being done on them. The psychedelic assisted therapies have been shown by research to be twice as effective at curing PTSD than other interventions. We're looking at 70% effective for some of these. And it is a 1 to 3 dose intervention. It does take, you have to space them out, but it is a, in my opinion, short and sweet way to intervene for PTSD. It takes about a year or less typically. And in 70% of patients, you're seeing a cure. Like they no longer meet diagnostic criteria. Also, a lot of this research has been done on veterans who have typically been a very difficult population to cure PTSD in. Positive psychology-based interventions. I've heard this also called strengths-based interventions. Those also work. My favorite guy who has really funny TED Talks is Sean Anker. He gives you a bunch of positive psychology-based interventions in a 20-minute TED Talk, and they all are evidence-based and they work in 30 days. It's amazing. So these are my tools. Now, I use a variety of these interventions depending on the client. It's a collaborative process. There are different lengths of treatment for these. Some of these have longer lengths of treatment. Some of them have shorter. ART and RRT is a 1 to 2 session intervention, which is amazing. CBT, DT, mindfulness-based, they're a bit longer. But right now, with some of these interventions, 30 days, there's a 30-day cure rate, which seems amazing. And I know it's like shocking to think your PTSD can be cured in 30 days, but some of these interventions have been shown to be that effective. So I want to encourage you all to look into these training programs across the US. They don't train you on these. These are CBT, sure, maybe. There are some programs that train you on CBT. But most professional training programs do not cover evidence-based trauma interventions. And if they cover it, it's brief. It's not a full training. So for most people, if you want to be a trauma-informed clinician, you will have to seek out this training and get it outside of, graduate school or medical school or whatever school you're going to. But I do encourage you to seek these out. They are worth it. It's not cheap, but they are worth it in the effectiveness and the rapid progress that your clients will show you. When you're using these interventions and causing progress, it also prevents professional burnout. At the start of my career, I was trying to do the, CBT models and 12 models because that was where I worked and that was what was, endorsed. And I will tell you that burnout is very high when you use interventions that are not effective. So if you are working with trauma clients, if you're working with clients with addiction, I would encourage you to seek out interventions that work as a way to protect yourself from doing this work. So my vision for the future, I imagine a world where addiction is seen as a symptom of life in a stressful environment instead of as a character flaw. I imagine a world where addiction and problematic substance use tapers off as we restore someone's sense of self through trauma therapy. We have a pull yourself by the bootstraps mentality here in this country, and I just don't know if that's helpful. It's okay to ask for help. It's okay to get help. And the challenge for us as clinicians is that when someone does ask us for help, that we treat them with kindness and dignity, and we use the most humane, effective interventions that are out there. And I just want to encourage you to look for those interventions because they work. And I'm proof of that. As someone who's, moved through the PTSD treatment herself and who does it, it is beautiful when you see someone, when you get to discharge someone from therapy because they've met their goals and they're no longer doing the thing that they came for. And I just, this past weekend, got to go see a performance, one of my former clients who's doing amazing. And I was crying the whole time because it was just so heartwarming. But that's what I want for all of us, a world where there's safety and humane treatment of people who are the sensitive ones and who have symptoms from the trauma that they have endured. So that's my talk. And thank you so much. I hope that was helpful. And if you have any questions, I'll be happy to answer them.
Okay, thank you so much. Now I have my microphone back on, and there was some great feedback as you were talking, because some of the things that you brought up were, I know things that I've never heard before, and from the reaction of some of our chat, was eye-opening as well, including that trauma can actually overload the brain to the point of blackout.
Yeah, passing out,
or
like falling out on the floor. Yep. Yep. Absolutely.
So when somebody comes to you and they're using the Sinclair method, which actually, let me back that up, because people don't come to you when they're using the Sinclair method. At Forward Counseling, you work with a doctor so that you actually can provide the Sinclair method in-house.
Yes. Absolutely.
Talk a little bit about that process of bringing the Sinclair method into Forward Counseling and why you did that.
Okay. The reason I did that was because in 2015, I got a divorce and started problematic drinking. And as a result of that, I'm Googling, like, what do you do about this? So I found the Sinclair method for myself. And just from Claudia's talk and Google, I think I found the book, The Cure for Alcoholism. And Dr. Wanderman, the doctor that works for me, I went to him. He's really progressive. He's been progressive his whole medical career. I went to him and was like, look at this. Have you ever heard of this? And he had not, even though he'd been a doctor for around, at that point, 40 years. And so I said, hey, can you prescribe this to me? Can we do this? And so we did it. I did Sinclair method myself and was completely shocked. I was completely shocked at how it affected my drinking behavior almost immediately, but I also noticed the effects it had on disassociation. So as someone formerly PTSD, one of the things I had to learn is how to manage disassociation. It's a superpower. I mean, disassociation is a superpower. Disassociation is the thing that protected me as a child from the horrible things that happened to me. But as an adult, I would slip into disassociation, not on purpose, I just zone out. And it makes focus very difficult. So I could notice immediately the effect on the drinking and the effect on the disassociation. And I said, we've got to do this. This is amazing. And so I started looking into who was prescribing naltrexone for PTSD, because I noticed this is going to work for PTSD. And Dr. Bruce Perry's info came up. So that's when I went down his rabbit hole of all his research. Now, he mainly works with children. So, the difference is I was an adult and noticing how it affected me. He works with children. I don't know of any pioneers who are using this with adults. We are using it at Forward Counseling, but I really don't know who else. We kind of figured it out by accident. And And we also figured out that some people, so Sinclair method works to fix addiction by itself. So you can just do Sinclair method and not drink. But we had people who would come back and they would say, look, I'm having, like, my anxiety's through the roof. Like, I can't sleep. I'm having all these weird thoughts. And like, you could tell, even though their drinking behavior was decreasing, they were still in distress. And those are the people where we were like, okay, this is probably a person with PTSD. Because at first we were just like, come do Sinclair method, do it as prescribed, read the book, here's the thing. But as we were doing it, we did notice that there were some people who continued to struggle. And the main thing we noticed was insomnia. And for those of you who drink, insomnia is a trigger for drinking. Like, if you can't drink and you're keyed up, if you can't sleep and you're keyed up, our answer is to have a drink, right? So I knew this was going to be an issue. If we didn't fix the insomnia, I was not going to be able to maintain sobriety for these people or help them maintain sobriety. And that's when we were like, oh, this needs to be, for some people, we need to figure out who just has a drinking issue and who has PTSD that is also including a drinking issue. And so from that point forward, we started including the ACE scale for everyone who gets the Sinclair method. It's part of our intake packet, actually. So we started with that. And if someone, if their ACE scale is a 1 or a 0, they're just on the Sinclair path. They're good. Like, we're like, you can handle this, call us if you need us. But for people who have an ACE score of 3 or more, we go ahead and say, like, I would like you to get assessed for PTSD. I will walk with you on this process. And that's really what we've done, is sort of provided 2 paths for people, is they can have the regular path, or they can do the trauma-informed path. And we have at this point an evidence-based protocol for a group therapy intervention that we have created and been studying for years that is highly effective at reducing PTSD symptoms. So not only did we create this path for people, the trauma path, we also created interventions based on the theories that I listed before, and then we've measured progress. And we've been highly effective for years with this model at this point. And it's great. We're slowly convincing other people in the city to do Sinclair method, but it's slow catching on, because the brainwashing that addiction is a lifetime issue, and all this that these clinicians have been told, they think I'm crazy when I tell them, hey, this works and it's like 70% effective for alcohol and it like cures it. People don't believe me. And I have to show them the evidence, or I have to say, like, hey, it worked for me, it worked for her, it worked for him. Like, maybe it is effective. So, people's defense mechanisms are there for a reason. They help us, but also it has been a slower acceptance than I thought. Like, hey, this is amazing, but it hasn't been as accepted as I thought. So I'm so glad you're doing this conference to spread the awareness.
Well, we're glad that you decided to take part. And one of the things that I use as a selling point when I'm talking to people in the medical and mental health communities is the versatility of the Sinclair method, and how if you pay attention, you can work it into other treatment programs that are already existing. And it sounds like that is exactly what you've done. And so in the TSM patients that you've had on either path, what would you say the overall estimate of the success rate has been?
All of our clients have been successful. So I haven't had anyone that hasn't been successful yet.
That is awesome, especially because you've been doing this for several years now. I actually remember getting you onto our provider listing when you added the doctor and added the Sinclair method in. So let's talk for a moment. And audience, you've still got some time to get some questions in. So please type up some questions and I will be thrilled to share those and ask those as well. So how does a person on the Sinclair method, because of the combination of just the process and clarifying the mind as they're reducing the alcohol, but also you brought up a use for naltrexone that I had not yet heard. How does that combination help facilitate the trauma-informed work that you do? Because I would imagine that as the alcohol is reduced, it's easier for somebody to then focus on the other part. So can you talk about that a little bit?
Yes, sure. The process, I guess uh, the way I would describe it is becoming present. So like in the book, The Heart in the Bottle, that's a good analogy for PTSD because it's like a wall. People say it's like my heart is, there's a wall around it, or there's just a wall up, or that's how a lot of people, they feel like maybe their heart is in a bottle. So what we have to do, and it's really tricky with people with PTSD, is slowly build their trust and slowly get their heart out of the bottle, or slowly remove a brick in the wall. But it's tricky because that needs to feel really safe for the person. And the problem with, it's not a problem. It's not a problem at all. It's actually the beauty. One of the beauties of disassociation and having your heart in a bottle when you have PTSD is that it is safe. It's really safe. And so convincing someone to be vulnerable, to let their guard down, to connect with someone is really scary. And our brain naturally does this thing called disassociation. It's like, oh, scared, scared, scared. I'm numb. I'm going to dump some chemicals and get numb so I don't have to feel this. But that process of disassociating disconnects us from others. So it's like, I'm safe, but I'm walled in. And the process is helping people relax and let their guard down without the disassociative wall flying up for protection. Because when that is up, and this is where trauma therapy is more than an art than a science, I feel it. So when someone's in my presence and they're present, I can feel that. When someone's in my presence and they're disassociated, I can feel that too. And I can't make any progress with them on the trauma when they're disassociated, because to effectively recover from a trauma, we have to integrate the thoughts, the feelings, the memories, all of that. So they really need to stay present in the feelings. Now, those feelings suck. It's going to be sadness. It's going to be loss. It's going to be shame. It's going to be all these yucky things. But feeling those with a safe person is actually the way to recover.
And I have a question, and I'm going to paraphrase this question from the audience. In your non-alcohol TSM addicted path, so just somebody coming in with PTSD who is using naltrexone, are they taking that daily? Are they taking that an hour before they come into their therapy session? How do you approach that?
So it depends on the person, and we have different doctors in town that prescribe different ways. Our doctor works with the therapist and we do a collaborative plan, but sometimes people come to us and they've gotten medication from their own doctor. I have people who take it daily. I don't recommend the daily dose because it does block the dopamine rewards cycle, and that's really fun. You might want that cycle. So I like to tell people use it as needed. And that's sort of the doctor and I's philosophy is, if you're using it for TSM an hour before you drink, if you're using it for trauma, using it, and also use with trauma, you can use lower doses. You may not need the same TSM dose. There's even some cool research on low dose naltrexone, but that's for another talk. I recommend people do it when they need to not disassociate, which is definitely for trauma therapy. But for some people, disassociation is fun. It's like daydreaming. It's like being in your head. It can be like this spacey feeling, and it kind of feels good, especially if you're used to it from having a really traumatic childhood. It's one of the things that through treatment, I negotiate with my clients is like, we're going to learn how to use a disassociation. I'm not going to take it away from you because it is like, it's a beloved thing. It's really a wonderful thing. So I work really with the client to help figure out what's best for them, what would work for them. I'm thinking of one client who was dealing with cravings throughout the day. She's the one that her doctor put her on it daily. And she takes it daily no matter what. She has become alcohol free, but she still takes it so that she doesn't have cravings. And it's working for her. She's been doing the daily maintenance for like a year or more. And I guess that's going to be their plan. But for some of our clients, we will do the therapy and then taper them off or let them use it as needed.
Okay, wonderful. And, we've only got a few more minutes, but one last question from me. And then if anything else comes in from the audience while you're answering, I'll go ahead and we can probably fit in one more. How does the Sinclair method make your patients, your clients, or you stronger than your drink?
I think the Sinclair method makes people stronger than their drink because it blocks the disassociation and they actually have control over their behavior. And that's the one thing people have said to me is I have control. Like I have no idea where this self-control came from. That's what I hear over and over. It's like, it's like the pill provides a level of self-control that they just didn't have before, not because of a character flaw, but because of the protective mechanism of their brain that was trying to protect them from trauma that they experienced. So that's how I think it works.
Well, that's wonderful. So again, thank you so much for taking time out of your weekend and for participating in our second annual TSM conference, Stronger Than Your Drink. We want to thank our sponsors, Work It Health and Ria Health, and our panel sponsor, Web Doctors. We're going to go ahead and take a short break, and we'll prepare for our next panel. So everybody get up, stretch, stay hydrated, and get ready for our next panel with Dr. Clifford Fields and James Kamansky. Bye, everybody.
Thank you, guys.